what is happening right now with infections and disease in Utah. So certainly at this time of the year, we usually are we're very concerned about respiratory diseases because it is about to become respiratory disease season. So CDC made a prediction. They used modeling to try to estimate how many people would get sick with our main respiratory diseases, which are RSV, flu, and COVID. And they created a model using mathematical processes to estimate what this year would look like. And what they came out with is that actually this year is going to look very similar in terms of the peak number of hospitalizations for respiratory illnesses compared to last season. So how did they get to this conclusion? They had a number of things they looked at. First, they looked at the fact that over the last 3 seasons, we've had actually very stable numbers of hospitalizations or peak hospitalizations for each year. And so from that, they estimated that they believe this is actually a general stable state and that we should expect similar amounts this year. The other thing they used when calculating how likely it was to have a bad season is they looked at the 24-25 season, and we know that last year was actually a really severe influenza season. Looking historically, it actually has never happened where we've had 2 severe influenza seasons in a row. So CDC is making the assumption that that will hold true. Hopefully it will. And we will not have a severe flu season, and therefore we should expect a similar, more mild flu season actually this year. And it will result in an overall pattern that's similar number of hospitalizations of last year. So of course, models are taking a fair number of assumptions in place. So the things that they are assuming when they made this model at CDC is they assumed, one, that there's not going to be some new, really virulent COVID or flu virus that comes out and causes severe disease. So they're assuming it's going to be kind of generally the same kind of viruses or same severity of viruses we've had the last few years. They also made assumptions about what kind of vaccine uptake we're going to have and also how effective these vaccines are going to have. So there are a number of things they used when they made this assumption, but that is the information they put out. So what's happening right here in Utah right now? Well, so right now we can look at ED visits. So this data shows us the the number of people who visited the ED for COVID, flu, and RSV. So COVID's in black, flu's in the teal, and RSV's in orange. And you can see this data goes all the way back to 2019 and makes it very clear. You can see the seasonal patterns. There's no question these are seasonal viruses. If we zoom in on this year right now, you can see we had a hump back in summertime of COVID, but we are actually quite low for all these 3 viruses in terms of ED visits at this time. I actually went and zoomed in really close on this data when I was pulling it, and there is no uptick yet in Utah. So right now we have a very low number of respiratory disease visits in the ED. So we are not seeing these infections yet really in Utah. Of course, that means those are people who are coming to the emergency room. We could imagine there's people who are getting mildly ill and don't need to come to the ED. And to be able to look at that, we actually can use wastewater data. So Utah has a very extensive ability to look at wastewater across our state. And we are able to monitor flu, COVID, and RSV. And so the data that we see for this is presented here. The top one really highlights the COVID, that's in yellow. It tends to always have a slightly higher level than the other 3 viruses, so it looks a little higher. You can see we had that summer peak, which we just saw in the ED visits. We saw it in the wastewater as well, and we're now quite low in terms of our wastewater levels of COVID. The lower graph, I just zoomed in so that we could see flu and RSV. And again, the last time we had a peak was last winter, and right now we are at quite low levels. So the wastewater data also suggests that we do not really have much of this virus in our state yet. So things to look at, though, outside of our state, we know that other parts of the U.S. are starting to have flu activity. The South is having distinct increases in the number of people who are coming in for care. Hawaii and Arizona, which of course is pretty close, are starting to see increases. And New York saw a jump in lab confirmed cases by about 49% last week. So there are parts of the U.S. where we are definitely seeing increases in flu activity. Intermountain, one of our colleagues at Intermountain shared yesterday that Intermountain actually has seen a doubling of the number of people who have come in and tested positive for flu in the past few weeks. This is through their whole region, so not just Utah, but the numbers still are exceptionally low. So even the Intermountain data suggests that we aren't really increasing much, but we might be starting to have that slight tip up. And then in terms of data about vaccines, so we know that Australia conveniently, Southern Hemisphere conveniently sort of predicts what's going to happen here because they get the respiratory season before we do. And they showed this past summer, winter for them, that they had the vaccine effectiveness was actually quite good. They got a 50% vaccine effectiveness of keeping people out of the clinic and the hospital during this past year. So that is promising. It's always hard to know exactly how well the vaccines we pick each year will work for flu, and this one looks like it's a moderately good one. So what does this all mean to people as clinicians? Well, really what it means is it is time to encourage our preventive measures. We really should be pushing people to get their vaccines, whether or not that's flu, COVID, or if they're eligible, the RSV vaccines. Infants, it's time to start giving infants antibodies, the monoclonal antibodies, if they were born to a mother who didn't get the RSV vaccine. So really now's the time to prevent future illness. So we really try to encourage people to go out and talk to their patients about this. So the summary of our vital signs right now is that respiratory season is just starting. Of course, at the same time, we have another issue going on in Utah, which is measles. So what is happening with measles at this point? So across the United States, so far this year, we've had over 1,681 confirmed measles cases. And it is really hitting across really most parts of the US. We have 42 jurisdictions that are reporting measles. Happily, the vaccine's doing well. And we see that actually 92% of the people who are getting measles are unvaccinated or not being able to show any vaccine evidence. So that means the vast, vast majority of people being affected by this are unvaccinated. When you consider that 90% of our population is vaccinated, yet 92% of the people getting measles are unvaccinated, it just shows you how predominant this is and how it really spreads within those unvaccinated communities. This disease is known to be quite severe, and the data from other states really suggests that. We are seeing 12% of cases being hospitalized across the United States. You can see here that littler kids are more likely to be hospitalized. Those under 5, 22% of them have been hospitalized, so it is definitely a more severe disease in those little kids. And then unfortunately, we have had 3 deaths in the United States. I'm hoping we don't go anymore. Certainly 3 is really tragic for a preventable disease. So if we look at the map of where we're having measles in the United States, you can see, unfortunately, pretty much everywhere is blue now. There's a few holdouts. Nevada, how is Nevada not having any blue? But it really is really widespread throughout the United States. And if you look at the numbers, Texas still is the highest, but actually Texas, their outbreak is over. They haven't had cases in over 2 months. They had their wave much earlier this year, whereas really the rest of the country is currently in sort of expansion mode. We, unfortunately, are a highlight right now in that there's an outbreak right around here at the Utah-Arizona border where we have over 150 people who have been reported to have measles. We actually know that the reporting is not excellent. We know a lot of people are not coming in for care. So we believe the outbreak in this area is much larger than the numbers we have. But it does indicate we have measles, significant amounts of measles here in Utah. So if we look at our information, we have a dashboard specifically on our website that goes over all the measles data in our states. If you scan that, you can get to our measles dashboard. Here is a map of where we're having measles across Utah, and you can see we do have a high predominance right here in southwest Utah. But it has sporadically come to other parts of the state, and we expect it to unfortunately continue to do that. In many ways, the cases in this area and also the cases in Texas and other states seed into other areas of Utah. So even if you're in one of those areas that still is white in Utah, I would not bet much that you won't see some measles arrive to your area. So far in Utah, we've had 74 confirmed cases of measles. As I said already, confirmed is people who go in and get tested. We know that there's probably quite a few additional people who have not gotten tested. For ours, we have over 99% of people who got measles are unvaccinated. We've actually only had one person who was vaccinated and had infection. We are seeing a pretty even split between people who are under 18 and over 18 who have infections. I will say, I think this actually predominantly just shows which groups of people it happens to be spreading in. When it gets introduced into a school, we see the number of under 18 go up. When it gets introduced into a sort of community event, we see the over 18s go up. So I don't think that right now reflects a significant risk to one group or the other. And then in Utah, we have had 8 hospitalizations, which is 11%. Happily, most of them have been very mild and have not needed significant treatment, but it does not mean we won't in the future. And I just dread when we might get someone who's very significantly ill with measles in our state. So just like RSV, we also have a way to detect measles among people who are not coming in, and that is through wastewater surveillance. So we can test wastewater to see if measles is in that water. And we have found it very useful over the last few months to use that to sort of know ahead of people arriving in our emergency rooms that somebody is in this area with measles. And really, data from wastewater doesn't reflect one person. It probably reflects a large number of people, because it's one thing that somebody goes to the bathroom, they flush the toilet, it goes into the sewer system, it gets diluted a lot, and then we take a sample out and test it for measles. You can imagine one person is actually really, really, really hard to detect. So it's probably our positives come up in wastewater when we have quite a few people. But we have seen a number of places turn positive, even when we don't know that there's people with measles in those areas. So it's been helpful to have this wastewater data to know what parts of the state are being affected, even if we can't tell through people coming into clinical care. Southwest Utah down here has consistently been positive for months. So we know that there are a number of people in this area with measles. Utah County recently had 3 positive samples in a row, so that suggests there are people there. We have known that there are people in that area with measles, so it isn't a surprise to us. And Salt Lake County just had a positive very recently. That's one that we're working with them to see if there's any possible cases related to it. So you can see we have abilities to see what's going on in the state, and we do know that measles is spreading throughout. So for all the clinicians either watching or in the room, I really want to remind you what you can do to try to protect your patients against measles. The first thing to do is if somebody comes in with any suspicion of measles, we really ask you to act to protect people, because measles is one of the most infectious diseases we know of. You put somebody in a room with measles, and if everybody else is unvaccinated, 18 out of 20 of them are going to end up with measles. It is crazy infectious. So we don't want somebody to come into your clinic and expose other people in your clinic. So if you have someone you have a suspicion of measles for, we encourage you right away to stop, put on an N95 respirator yourself. Don't trust your vaccine. These vaccines are amazing, but there's no such thing as perfect. So put on the mask to make sure to protect yourself. We suggest that you put the patient into a room immediately. Don't have them wait in your waiting room. In fact, even put a mask on that person as you walk them to the room so that they don't expose other people just by walking by. I know it's not super common, but if you happen to have a negative pressure room in your clinic, put them in there so that the air pulls into the room and doesn't push virus back out to the rest of your patients. And then if you have nurses or other people caring for someone who you think might have measles, make sure they're fully vaccinated. And then when you actually are talking to the patient, there's a number of things that we would ask you to talk about. Make sure you can check what their vaccine status is. Certainly, if we have somebody we're not sure what they have, it turns out measles kind of looks like a lot of diseases. It has the rash, it has a fever. And every little kid, I know I'm a pediatrician, every little kid comes in with a rash and fever, right? It's like so common. So we know there's going to be a lot of people who kind of look like measles and you don't know what you're working up. Ask about their vaccine status. That right there can really tilt the tables towards this is likely measles versus not. Talk to them about their exposures, their travel, and then review the symptoms about what were the progression of symptoms. Things we don't want you to do, as I mentioned, we don't want them to walk through your waiting room and expose other people in your waiting room. If at all possible, and perhaps somebody calls in and says they might have measles, have them enter through a secondary door somewhere else so that you can put them in a room without exposing others. Having them put on a mask is really useful. We also encourage you to call us at the Department of Health and Human Services or your local health department really early on if you have a suspicion of measles, because we can help you try to identify anybody else who's at risk and get you the right resources. The other thing we don't want to do is if you see somebody who you think might have measles, please don't send them to the ER without telling the ER that that's what's coming. It's of course just as bad to expose the ER to measles as it is to a waiting room. So we really encourage people to call ahead if they're sending the patient anywhere. And then what the kind of testing to determine if somebody has measles, the gold standard is measles PCR. This should be really quite accessible to all the clinics across the state at this time. All the major laboratories are doing measles PCR. You might want to check with yours whether or not they do throat or NP swabs, because some do one, some do another. This PCR testing is exceptional. It's really reliable as long as it's been taken when the person starts to have the rash to 10 days after. When it's 12 days, 14 days, it starts to be more false negative, so it really should be in that beginning period. The State Public Health Lab does actually have the ability to do testing, but we try to prioritize that to people who don't have insurance or might not be able to pay. So if you have someone who you are worried about them actually being able to afford the testing, certainly contact us and we can do testing for you. I will mention antibody testing. I hate antibody testing. It is so unclear. It is so confusing. So in general, I'm just going to say, please don't do antibody testing if you think somebody actually has measles. It just makes everything super unclear. The one time that antibody testing is useful is if you have somebody and you're not sure if they were ever vaccinated and you're just trying to figure out if they need the vaccine. Not because they're sick, but just because they need it, whether or not you're trying to understand if they're need the vaccine. That's when antibody testing is really useful. So in general, test people with PCR if you're considering they might have measles. And then finally, on our website, we do have a whole page for resources for clinicians. The QR code will take you there. It has a lot of different information and resources that I didn't go in here into depth, but feel free to go there and get more information. So what do I see in my crystal ball for Utah? Unfortunately, I see more measles. And I think really the important thing is to make sure you all have it in your mind that is something that might walk into your clinic and be prepared for possibly seeing this. So with that, now I'm going to turn to the main topic of this conference, which is looking at issues for rural health. And so we know there's been a lot of discussion about disparities in rural health. It's actually one of Governor Cox's priorities for his second term. He specifically called out the number of areas in Utah that don't have healthcare professionals and have a shortage, and he specifically called out improving this. When we look at the map of the US, you can see here when it's darker green, it means there's more of a shortage of healthcare professionals. The lighter green is less, it's still a shortage, but it's less of a shortage. And the gray means there's no shortage. Utah happily doesn't have any of the darkest green when we look specifically at primary care, but we have a lot of green. And of course, primary care is just one type of doctor. If we look at other types, there's actually getting more worrying. So here's on the map that's blue, we have mental health providers. And you can see again, the dark blue is where we have a really severe lack. And unfortunately, Utah has a number of areas that are dark blue, and most of our state has some level of blue. So we have a significant shortage of mental health care providers. And then the other map is looking at how far people have to drive to get birthing services. And you can see a large part of our state, people have to drive at least 30 minutes, if not 60 minutes. And so there's so many pieces here that mean that that our rural populations just don't have the access to healthcare that we think is ideal. And I think probably everybody in this conference knows that. And it's something that I think is really important. So I really wanted to look at what is that doing to the health of our population. So CDC has looked at urban-rural health disparities, and they have identified 5 diseases or disease categories that cause the disproportionate amount of death in young rural populations. And they specifically have death is noted in because of heart disease, cancer, unintentional injury, stroke, and chronic lower respiratory disease. And so those are the diseases I decided to look at for Utah, see how we're doing with our rural and our urban populations. So first, just quickly throw up a map of how the Department of Health and Human Services defines our different kinds of population. So in Utah, we actually divide our populations into urban, rural, and frontier. You can see, not surprisingly, we have the Wasatch Front as our urban area, and then we have a rural, but then we have this extreme, which actually a lot of states don't define. We have the extreme frontier areas where we have very, very few people. So throughout the presentation, I'll be presenting data for these 3 different types of populations. I will say right now, I really mostly will talk about the comparison between urban and rural, and that's because frontier tends to be so small and have so few events or people. It's hard to draw strong conclusions, but you'll see throughout it, the frontier areas tend to match the same pattern and actually are usually more extreme than the rural areas. So when I looked at our death rates for everything in Utah, it became very apparent that we do have a higher death rate in our rural populations. So here, unfortunately, the blues are a little too similar. So the lower blue is the urban area, the middle is the rural area, and the top is our frontier area. And so you can see we do have significantly higher rates of death over time in rural Utah and in frontier Utah. So the question I had is, what is causing these higher rates of death? And so I want to pause for a second and just say, I am currently, and through a lot of this talk, I'm going to be comparing rural and urban Utah. And I don't do that because I think we all should become urban Utah, and we don't want to strive for the perfect of urban Utah. There is no question urban Utah does not have perfect. But the reason I compare them is because I think it's what's achievable, right? If we have a certain amount of cancer in urban Utah, we should be able to achieve that for our rural residents. So I'm using this data to be able to say there is a difference that we should be able to achieve instead of just aiming for something that maybe is very, very impossible. This is things that are possible. So that is why throughout this talk, I'm going to be comparing urban and rural, not because I really think that there is a gold standard out there. So the first thing I did was I just actually looked at the average age of death, and I was actually super surprised. So if you look at this graph, it appears that urban Utahns die at a younger age than rural Utahns. And I was super surprised by that. Why would that be true? That's not what I believed. These higher death rates make me think that shouldn't have happened, right? Why the heck are urban Utahns dying earlier than rural Utahns? And of course, there's a lot of things that are different between people who live in urban areas versus rural areas, beyond just what area they live in. There's huge amounts of socioeconomic factors that affect people's health that are different between these 2 areas. Unfortunately, we don't have excellent data on socioeconomic data. So we know who dies, but we don't know what socioeconomic strata they come from. So it's very hard for us with data in the Department of Health and Human Services to really analyze that difference. But the one thing we can do is we can narrow it down to race. And so race, while not appropriate, is actually somewhat of a proxy for socioeconomic status. And so what I did is I just narrowed down the same analysis to just look at white Utahns. So we're holding constant the exact race of people in these different areas. And the factor stays exactly the same. In fact, we still see urban Utahns are dying at a younger age than rural Utahns. I was quite surprised by this. So something is happening that is causing this difference that is not based on rurality. So the next thing I looked at was the age distribution in our populations. And this is very obviously different. If you look at this graph, the blue bars are our urban population, the orange are rural, and then gray is frontier. And you can see the blue tend to clump towards the young side, whereas the orange and gray tend to clump towards the older side. So we do, without a question, have older people living in our rural and frontier areas compared to our urban areas. This is generally known to be true through a lot of the United States, so we are not unique in that way. But when you think about, if I look at the causes, how many people die from any kind of disease, it is going to be skewed if you have different age populations. Unfortunately, we know people who are older are more likely to die. So if you have an older population, you will automatically have a higher death rate. So in order to correct for that, we usually do age adjustments. So we take two populations that have different age structures, and we make them so that they match an age structure and then compare their death rate. And so I did that, and actually a large amount of our differences disappear. So this data right here suggests if we take out age differences, the death rates in urban and rural Utah are actually not that different. I was surprised. I don't know. Maybe you are. Maybe you aren't. I was surprised by this. And so at this point, I realized this might be too big a picture to look at. So I decided to go a little bit narrower, or more detailed, I guess. So then I looked at all-cause death for Utahns based on which age they were. And this is data from 2015 to 2024, so quite a few years combined together. I'll say here in this graph, I'm showing two different graphs, and that's because if we put all ages together, the death rate in people who are over 65 to 75 is so much higher than those who are in their 30s that you can't see the 30s. So on this graph and ones going forward, I'll often have it so I have two different axes, so you can actually see the data for both groups and not have one be super squished down because the other is so big. So yes, here I have our urban, rural, and frontier populations by how old they were when they died. And throughout the presentation, I'll show when there's the urban population has a higher rate using a red up arrow, and when the rural population has a lower rate by using a green down arrow. And so when I do this, then the drama starts to be obvious. This is what we are concerned about. So if you notice, we have red up arrows, meaning higher death rates in rural areas for our young population. So it definitely shows us that we are having higher death rates in young people in rural areas. That is extremely concerning, right? Interestingly, we actually have lower death rates in our older population in rural areas, which probably suggests some protective factors, which when I do the presentation for urban population, I'll have to look at what is the protective factors for that. But what I want to look at is why the heck are we having young people die in our rural areas? So to do that, I went back to the CDC information about what was causing increased death in rural areas. And I focused in on these 5 areas to see what it looked like in Utah. We know that there's a number of diseases that Utah is.
And I'm happy to move. I really am.
United States. And I thought maybe that's the case here. Let's see what our data shows compared to what the CDC national data showed. So first, I pulled up cancer deaths, cardiovascular disease deaths, and stroke deaths. And what I found is there is no difference, or there's actually people die less frequently in rural areas. So these 3 big disease categories do not appear to be driving this increased death rate in young rural Utahns. So we do not match the national picture in this way. Our rates in these specific disease categories are not more severe in rural Utahns. I then went and did chronic lower respiratory disease deaths, and this one did have a higher rate of death in our rural areas, but it was specifically in the older population. It was not in the younger population. So it still didn't answer to me why we were seeing so many more deaths in our young population in rural Utah. And then I finally did deaths due to unintentional injury, and that's where things really started to be more apparent. We clearly see increased death rates in our rural and our frontier. Our frontier is actually more exaggerated than our rural areas when compared to our urban populations. So this is where we are seeing young rural Utahns die more than our urban populations. It really is unintentional injuries. So when I go to the CDC data, I say I can cross out 3 of them. CLRD is a little bit of a fact, but most importantly, it's unintentional injuries. So what is an unintentional injury? So they can be falls, they can be hiking trip accidents, but the biggest one is motor vehicle crashes. And so if you look at our data for motor vehicle crashes here in Utah, it really does show what a huge difference between death rates in our urban areas and our rural and frontier areas. So we see increased death rates in those people who are young, who live in our rural and our frontier areas, and that's specifically from motor vehicle crashes. So this is important. I wanted to highlight this because I think we always hear of health disparities between urban and rural areas, and we are tempted to invest money in all these different areas. But I think it's useful to look at the data to know which areas are the one could have the biggest impact. And from this data, it suggests to me that really preventing injuries and preventing motor vehicle crashes can put us ahead a lot more than if we were to invest in other areas. So what can we do? I mean, motor vehicle crashes are one of those things that seem so big that it's really hard to do anything about. But I do think it's really important to remind people that their big, fancy new cars are still not completely safe. In 2023, there were over 23,000 passenger deaths. Deaths of people in a vehicle in that year in the United States. 49% of those people who died were not wearing a seatbelt. That to me is amazing because we know that the vast majority of people are wearing seatbelts. So if we have most people wearing seatbelts, yet half the people who died weren't, it shows what a high risk of death it is if you are not wearing a seatbelt. And if you look at just at nighttime deaths, it actually increases even more. Over half, 56% of the people who die at night were not wearing seatbelts. So seatbelts, we know from the data, have a huge ability to decrease the risk of both fatal and non-fatal injuries. So as in a passenger car, you have 45% chance less of dying from an injury and 50% less of having a moderate to severe injury. That's still true in trucks. I think some people think their trucks are magical and they are totally safe, but it's not true. Trucks, actually, putting on a seatbelt protects you even more than if you weren't wearing one. And the other thing I hear from people is now we have airbags. There's no reason for seatbelts, but that's actually not true. Airbags are designed to work with seatbelts. They do not replace them. Actually, injuries can be quite severe if people don't have a seatbelt on and the airbag goes off. So these are the kind of things that I think just using a second of your time with your patients to talk about how basic things like seatbelts can really save lives. And then other things to remind patients of the basics is alcohol use and driving. Happily, Utah doesn't have as high alcohol use and therefore doesn't have as high road fatalities related to alcohol, but we still have it. And we really should try to prevent that. We know distracted driving. We all are tempted to use our phones while we drive. You get that text and you want to know what it is. We know that is a factor in over 25 to 30% of all crashes. So trying to talk to people about not using that. And then teens, we know our high injury rate from this. So with this, it really segues into what I wanted to talk about is my next topic, which is traumatic brain injury. Because of course, traumatic brain injury and motor vehicle crashes unfortunately go hand in hand. So traumatic brain injuries are any injury to the head. You can do it in many different ways. It can be penetrating or it could just be blunt force. But the end effect is really very similar. You have both this primary impact where you have the obvious problems with your head, where you might have a big contusion, you might have actual skull deformities. Those are obviously very tragic, but even more insidious, though, is the secondary effects where we have sort of inflammation in the brain. We have decreased oxygenation, possibly because of the swelling and injuries, and we get neurotoxic cascades. You have really diffuse injury of the brain, even a fair bit after the immediate injury. And so the effects of a TBI, I think many people are familiar with the TBI, what happens in the short term. I mean, I feel like every parent always says, oh, I can't let my child go to sleep after they've had a head injury. That's the classic understanding of what short-term injury TBI is. It's where you get this nausea, you're vomiting, you're out of it, you're really tired, you might have visual changes. Those are the acute things, which of course are terrible, but what's much more worrying is that we see significant long-term effects of head injuries. So we see things such as dizziness and vision changes, but then we get things that are actually cognitively affected. So people have memory deficits, they have emotional liability, they get a lot more anxiety, depression. So we have long-term consequences of TBIs that are much bigger than I think a lot of people ever think about. And we can see this in public health. We can see that people who have a history of TBI are much more likely to be involved in the justice system. They're much more likely to be involved in risky substance use behaviors, and they are much more likely to die from anything. So not just something directly related to their head injury, but from all types of causes. So TBIs have a really long impact that many people don't recognize. Here in the US, we have actually pretty consistent numbers of TBIs each year. I'm actually really impressed by how wiggly this all is for every year. Clearly a pattern. This is from 2018 to 2024. So there is a high number of TBI, and this is deaths in the United States each year. So in 2021, we know there were 69,000 TBI-related deaths, which is 190 each day. We had over 200,000 TBI-related hospitalizations, and then we had an unknown amount of ED visits where people went home without being admitted to the hospital. So TBIs are actually quite common and quite concerning. So for the economic-minded people in the room, we also have huge cost of TBI. So an estimate from a paper estimated that in 2016, the cost of non-fatal TBIs in the U.S. was over $40.6 billion, and that really was spread between the different types of health payers. Medicare takes the brunt of it, and that is because older people tend to have more TBI. I'll get to that in a minute, but it really is costly to many different parts of our health system. Here in Utah, we know that in 2023, we had a total ED cost for non-fatal ED TBIs of $339 million, so very expensive just for our states. And the average cost of a TBI, non-fatal TBI visit to the ED was $24,000. These are expensive events. So what actually is our causes of TBI? So the most frequent cause of a TBI is a fall. And over half of all TBIs that get hospitalized are a result of a fall. It depends somewhat on your age group, whether or not you fall and have a TBI. So it turns out the people under 17, half of all the emergency department visits for TBI are because they fell. People over 65, it's actually 81% of TBI visits are because of a fall. Older people definitely have an increased risk of falling and hurting their head. But then we also have a very high rate of TBI because of motor vehicle crashes, sports injuries, and then firearms. Firearms are the most likely to be a fatal TBI. And then hospitalizations from TBI, we see about 50% of them are due to falls and 20% of them are due to motor vehicle accidents. So if you're considering fairly severe, because they had to be hospitalized, those two cause a lot of severe TBI. So who can have a TBI? Anyone can have a TBI. I religiously wear my bike helmet. I don't want a TBI. I encourage everybody to do the same, but there's so many ways we could accidentally hurt our head. We do know there's certain people who are much more predisposed to having a TBI. That is definitely older people, so people over 75. They account for 32% of the TBI hospitalizations and 28% of TBI deaths. We know they don't even start to make up that much of our population, so they are disproportionately affected. And then the other group is males. So I don't know how many people are surprised by this, but men are 2 times more likely to be hospitalized for TBI and 3 times more likely to die of a TBI. So it is really clear that we have a difference in gender behavior and how people, how how risky behaviors people engage in and therefore have TBIs. Just a quick call out about TBIs in older adults because they are so susceptible. So it is a harder diagnosis. We know a lot of times people have already underlying mental difficulties. So they might have dementia, they might have strokes. And then of course that can kind of look like TBI symptoms. And so it's very hard sometimes to diagnose TBI in this population. And at the same time, they also have an increased risk factors. They are often on anticoagulants, antiplatelets. So if they do just even slightly hit their head, they could have a significant bleed that in most other people would not affect that. So certainly TBI is quite concerning in our older population. So, okay, enough about general TBI. What's happening about TBI here in Utah? So we have a survey that we do every year where we ask a huge number of questions. And one of the questions we ask is whether or not somebody believes they've had a TBI. And so we found that 36% of Utahns report that they have had a TBI. And that is different between our urban and our rural respondents. So people in the urban areas, 35% of them said yes, whereas 39% of rural respondents said yes. And that unfortunately reflects a true reality of how many people are getting injured, that it is more common to have a TBI in rural areas. We also asked during that survey what actions those people took after their worst head injury. And you'll see 36% of people said they did nothing. So it wasn't bad enough to go and get any care. That's reasonable. I probably fit in there. But next most likely is people go to the emergency room, then their outpatient doctor, and then they might miss a day of work or school. But what's interesting is when we now divide it into our urban and rural, we see quite a difference. So rural is represented in purple. And you see, instead of no action, we now see the majority of people in rural areas actually have to go get an emergency room visit to be able to be after their head injury. This is something that we can't say why this is. Is it because they're more significant injuries, or is it because they have lack of access to other types of care? And so they feel they need to go to an emergency room to make sure they get some care that is maybe easier to access in their urban areas. We don't know the answer to exactly why that's different. But we do want to know, it could also be because severity of the injury, right? So how do we look at severity of injury? Well, we can look at the levels of care that is needed for TBIs here in Utah. And so we can look at non-fatal emergency room visits, hospitalizations from TBIs, and then deaths from TBIs in Utah. And what we find is that there is a distinct increase in the number of people who go into the emergency room for TBI and also who die from TBI here in Utah in the rural areas. So we can say that the higher non-fatal ED visits, we don't know. Is that again because of severity, or is that because of access? We don't see a difference in the amount of people who are hospitalized for TBI between the two areas. So it's interesting to say they're going into the emergency room, but they don't get hospitalized. It might suggest again a concern about access and people going into the emergency room when they're not sure. Whereas in an urban area, they might and see how it plays out. But we definitely know that we have a higher death rate from TBI in our rural areas, which probably is a combination of both severity and access to care. And then the other thing we ask people in this survey is what was the cause of their TBI? And as we see here, the majority of people are reporting falls and then sports related. Interestingly, when we divide this by rural and urban, falls still stays quite high for both, but then we get quite a difference. So the second most common in the rural area is motor vehicle crashes, whereas the second most common in urban areas is sports related. So we have quite a difference of why people are getting head injuries in our urban and rural areas. And it comes back to, unfortunately, car accidents. So when we do this, and I looked at this by cause of TBI in our data sets, we can see this outcome. We have a definite increase in motor vehicle related TBIs in our rural areas. We also have an increase in suicide related TBIs in our rural areas. But then actually we have more hospitalizations from assault related TBIs in our urban areas. So we do see a difference. I will point out that the axis for the assault related TBIs is smaller than the other two, so don't think that all the TBI, there's tons of TBIs from assaults in urban areas. It's just, there is a difference. It's uncommon. But we certainly see that motor vehicle crashes and suicides are a significant disparity in why we have head injuries in our rural areas versus our urban areas. So what can we do about this? Certainly we want to change it. We do have a number of resources that we can recommend to you. And in fact, we have a team specifically at DHHS that works on TBIs and actually all sorts of violence and injury type work. They have a number of resources here. They also, Tracy is the person who leads this and is happy to talk with any group that's interested in doing additional training or concerning additional resources that you would like. So I encourage you to reach out to her if you have any thoughts. And then finally, getting into immunization. So I think we all are very aware of the increasing amount of vaccine hesitancy in our country. And it's not just our country, it's our whole world. There's a lot of increase in vaccine hesitancy. And unfortunately, that is true here in Utah as well. So this is the percent of kids who are fully vaccinated at the start of each school year. And you can see we have gone down. And of course, this matters because these diseases that we're vaccinating people against are really significant. So this is the number of these vaccine-preventable diseases before the vaccines were introduced. And this is the number in 2020. So vaccines have been amazingly successful, and yet we are having people pull back from them. Again, if we want to talk economics, for every dollar that we spend on vaccines, healthcare payers save $3.30, and society in general saves $10.90. I don't know what stock's going to give me that much money in return. I will take it. So we really should be investing in vaccines. They're amazing, amazing health solution. So go back to measles. Measles, of course, is one of the amazing vaccines that was really successful. We can see that here. This is the number of people who had measles each year. And you can see very clearly how quickly the number of people dropped off after the vaccine was introduced. Tragically, that line right there is at 880, and it has gone up more. But it shows what we have achieved and what these kind of things can do to prevent disease. So what is the significance of this for rural and urban areas? We can clearly see a difference in our vaccine exemptions in our different areas. So Utah has a law that allows students to be exempt from vaccines for personal beliefs, and it's a very simple process to exempt students from the vaccines. So we can look, and here we have the Wasatch Front, which is our classic urban areas, and then orange is our non-Wasatch Front, so rural areas. And you can see the number of students who've had vaccine exemptions have all gone up somewhat, right? In the last few years, we have more and more kids requesting vaccine exemptions, but is much more dramatic in our rural areas. And so we are definitely having a significant lack of vaccination in our rural areas. Here's another data similar to that, and it's from a survey where we ask about specific vaccines. And you can see our rural areas, which in this graph are represented as the blue bars, are all lower than our urban or suburban areas. So we are definitely having a drop off in vaccine uptakes more heavily in our rural areas than our urban areas. This doesn't just apply for childhood vaccines. It actually is, we see the same thing for our adult vaccines. This is adult flu vaccine and adult pneumococcal vaccine. The teal is urban areas. So you can see there's a higher rate of vaccination in our urban areas compared to our rural and frontier for these adult vaccines as well. And if we look over time, this is from 2020 to 2023 for urban, rural, and frontier areas. And you can see all of them have a slight decrease, but unfortunately that decrease is more significant in our rural and frontier areas. And they also started out from a lower part. So we definitely have a lower rate of vaccine over time and differential in these places. So this comes out if we look at the distribution of kids who request exemptions. This is a percent of kids who are adequately immunized. So the darker purple is a lower percent of kids are immunized. And you can see Southwest is quite high, it has quite a few kids who are not fully immunized. But in general, the darker purple is the more rural areas. It's not completely correlated, but it is at least somewhat. And that does unfortunately match fairly well with our map of measles. Southwest was unfortunately set up as a prime place to introduce measles and have it spread. And that's exactly what has happened in such unvaccinated communities. And sometimes it's sub-communities. Once you have something like measles introduced, it can spread really easily. So why aren't people getting vaccinated? Yes, there is a coronavirus on there for a reason. There's no question coronavirus had a negative impact on how people view vaccines, but it started before that. We can see the difference in rural and urban attitudes by a number of surveys. This one was done by Kaiser Family Foundation, where they asked people if they trusted the vaccine for their kids. You can see the dark blue is very confident about the vaccine, whereas the green is not at all confident about the vaccine. And you can see almost a complete flip between the urban and rural areas about their confidence about the vaccine, meaning the parents just really didn't trust the vaccines. And we have done surveys about why people are not getting vaccines. And the interesting thing here is we find that in the rural areas, more people are likely to say that the vaccines, they don't trust the vaccines or they don't think they're safe or effective. And so we are definitely seeing more vaccine distrust here in Utah in our rural areas. On the other hand, in urban areas, we see people saying more things about not being able to find a location or have the time or money. So it's more access issues in our urban areas. So what can we do about it? So over and over and over, there's been surveys done to ask about who do you trust most about your healthcare. And happily, doctors have stayed at the top, and doctors continue to actually, it doesn't degrade much. Even during the pandemic and after the pandemic, the trust in doctors has stayed quite strong. So I want to just highlight that all of you as doctors or nurses or healthcare professionals, 38% of people trust you to a great part. Me, it's 11%. So I have to rely on all of you to go and talk to your patients and your communities. So with that, just some additional resources. There are a number of trainings out there about how to talk to people who are vaccine hesitant. I know it's a painful conversation. I remember doing this with my patients even a number of years ago, where I'd have pediatric patients who just were very hesitant about getting vaccines. And I know it's gotten worse. But I think we all have to try to improve how we do this and learn and try to adjust. So with that, thank all the people who've helped me with this, and I am happy to take questions.
We just had a question come up in the chat online, and it says, a news report this morning said that a new flu strain is running rampant in Japan, the UK, and Canada. It is H3N2 strain. The 2025 vaccine covers one kind of the H3N2, but not this one. They report that the current vaccine is only 40% efficacy against preventing severe illness and not in prevention of the disease. Please comment.
Yeah, I've seen that report. Japan's been mentioning for a while now that they had an increase in influenza rates. When they dug into the data that I saw, the rates really were not that extreme. They could see their increase of their season, but it wasn't much more than expected. I will say a 40% protection against hospitalization is still actually, for flu, a pretty decent protection rate. We know that many of our vaccines are not exceptional about preventing illness. And I will say, as much as I wish we had diseases that could keep us so we never got anything, having vaccines that keep us from getting in the hospital is really the primary goal. If we can keep people so they're healthy enough to stay home and suffer through, unfortunately, it's still a win. And so having vaccines that are still 40% effective is actually a pretty good vaccine for us in the flu world.
And then we did also have a comment that just said, in the traffic fatality review, we see rural youth driving dangerously and unrestricted on dirt roads too frequent.
And I'm not sure if people can hear the people online from the mic. Can they hear the mic? Okay.
My question. Thank you very much for your presentation and sharing this really interesting data with us. My question goes along with that comment about higher rates of death in younger individuals in rural areas. You mentioned that, and my thought is why? Given us the data, why do we have higher rates of youth dying on roads in rural areas? It could be as simple as more miles driven in rural areas, more miles driven on poorer roads, higher rates of speed, single lane highways, those types of things. What are you conjecture maybe a little bit as to the why?
Yeah. So I completely agree with you. I think this is why do more youth die in motor vehicle crashes in rural areas than urban areas? There's no question it's multifactorial, right? And I think there is some truth that it is probably they are just on the roads more often because they need to be to get to different events. We don't have data to be able to dive much more into that. I think it is something really useful, and I suspect it is. Different areas have different issues, right? So I think this is where getting into local health departments or local health is really important, and recognizing what is the road conditions in your area. What are the general approaches that parents take for having kids go out late, and thinking about what kind of things are affecting the health in that area. I think it's unfortunately you can't look at it as a big picture because I think it's so different in different areas.
The early parts, you mentioned the rates of wastewater testing for COVID, influenza, and other diseases. It seems that was a rate difference, while the testing for measles was more binary. Can you explain how that sort of works? Are you testing for like parts, sort of math, or is it just a binary but over wide areas?
So my wastewater experts are not here, but I will channel them. So the RSV, flu, and COVID, we are doing quantitative assays. So we can tell exactly how much of the virus is in the wastewater we're collecting. Whereas measles, we're actually fairly early on in it, and it is more of a qualitative. So we can say it's there or it's not. So we aren't at the point where we can do the exact amount per milliliter. That is something they are working on so that we can trend it over time. In truth, right now, it doesn't matter too much to us. Just knowing that measles is in an area is enough for us to be aware of, right? I kind of actually hope we don't want to invest in quantitative measles because I want it to disappear. It shouldn't be here, right? We shouldn't have to quantify the amount in the water. We should just be like, it's not there. And whenever it's there, that's significant. So it's an assay difference, and it could be changed. And I will just do a blatant plug at the end. We have listservs. The first one is this series. It's every 6 months. If you want to sign up for this series, you'll get a reminder about it every 6 months. The middle is our urgent health alerts, where we send out things that are the most important. We try to use it very rarely, so you should only get maybe 1, 2 if it's a bad month. And then the last one on the far side is our public health updates that we send out weekly, and it's either resources, information, it might be a training. We try to send out things on all different types of public health issues, so we'd love if you guys sign up and use these resources.